Hello everyone. Today you're gonna watch my face talk about panic disorder and why it's important to understand from an emergency medicine perspective. Okay, I'm going to talk in a very calm, quiet tone so as not to incite any panic. Psych! That is not how panic disorder works. It's a neurochemical dysfunction of the fight or flight mechanism. Its onset is in the third decade of life, like most anxiety disorders, and it affects women twice as often as it affects men. Yay, men. What you need to know is that people with panic disorder consume medical resources way out of proportion to the severity of their illness or their level of actual need. Furthermore, many people with panic disorder present initially to the emergency department, opposed to their primary care physician, with a litany of somatic complaints. Panic attacks are unpredictable and not exactly triggered by specific stimuli in a reproducible way, but more on that later. Theories about the cause of panic disorder abound. Please take a moment to read them silently to yourself. Do you feel that? Some of you feel that. Please tell me at least one of you feels that, because otherwise that is just an epic failure. That is panic. Now imagine that feeling at that intensity coming out of absolutely nowhere and continuing non-stop for 15 minutes. A panic attack feels like you're about to die. When one feels as though one is suddenly about to die, where does one go? Not to the nearest phone to schedule an appointment with their PCP. They go see you in the ER. Speaking of ER, I mentioned earlier that panic disorder starts in the third decade of life and is more common in women, but I found one study about the demographics of patients with panic disorder in the ER, and it found that 53% of them were male over the age of 40. And they were presenting with more somatic complaints opposed to the psychological complaints of a panic attack. And you're all like, what are these complaints, Amber? A person having a panic attack will present with a combination of the following symptoms: palpitations, pounding heart or tachycardia, sweating, trembling or shaking, chills or hot flashes, a sense of shortness of breath or smothering or a feeling of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded, faint, depersonalization, feeling detached from yourself, sort of everything is surreal, a feeling of losing control or going crazy, a fear of dying, or sensations of numbness and tingling. Conveniently, in order to meet the DSM criteria for panic disorder, a patient must manifest 4 or more of those symptoms. The symptoms peak within 10 minutes and generally last 10 to 30 minutes, since it's hard for the body to sustain a fear response for long periods of time. But people can have repeated attacks sort of one after the other, and in very rare cases they can last up to an hour. To make the diagnosis of panic disorder, the attacks cannot result directly or physiologically from substance abuse, medications, or some other psychiatric illness. And they have to be associated with more than 1 month of subsequent persistent worry about having another attack, the consequences of attack, or changes in behavior related to the attack, such as agoraphobia. Colloquially, we think of agoraphobia as someone who is so riddled with terror and anxiety or anxiety that they can't leave their house, but really agoraphobia is any level of anxiety that prevents you from doing the normal behaviors or going to the normal places that you would go for fear that you're going to have an attack. For example, maybe one night you were driving your mom's car to Strongsville Library and you had a panic attack. So from then on, you would shun convertible Mustangs and a perfectly lovely library for fear that those things would trigger another panic attack. When you look at all the symptoms of a panic attack, you see that they could easily indicate a veritable buffet of life-threatening conditions. So now you have a differential diagnosis that includes angina, MI, dysrhythmias, mitral valve prolapse, pulmonary embolus, asthma, hyperthyroidism, hyperparathyroidism, hypoglycemia, pheochromocytoma, TIA, not to mention all the other psychiatric disorders that could cause panic attacks like schizophrenia, depressive disorder, PTSD, or somatization disorders. Because of this, and the fact that no test, lab, or imaging is specific for panic disorder, what we're making in this case is a diagnosis of exclusion. The cornerstones of panic disorder diagnosis are H&P and a mental status exam. There's this thing called the PRIME-MD, which is the Primary Care Evaluation of Mental Disorders, and it's a questionnaire that is not usually given in the ED, but as the name implies, is very useful in the primary care setting. When you give a mini mental status exam, it'll be normal and reveal an obviously anxious patient. When you're taking the history, if they have situationally bound attacks occurring predictably in response to a stimulus, this supports a diagnosis of a phobia type disorder. You also need to exclude the involvement of alcohol, nicotine, LSD, ecstasy, marijuana, theophylline, caffeine, sympathomimetics, anticholinergics. 7 to 28% of people with panic disorder have a history of substance abuse. You need to look for a family history or a personal history of panic disorder or any other psychiatric disorder. And then assess for any precipitating events, phobias, agoraphobias, obsessive compulsive behavior, suicidal ideation or plan. 10 to 20% of people with panic disorder have a history of a suicide attempt. Here's a note. You will remember Hickham's dictum, which said that a patient can have as many diseases as he darn well pleases. So that means even a patient who presents with what you can clearly identify as a panic attack, who has a diagnosis of panic disorder, needs to have their symptoms adequately investigated. Just because you have panic disorder doesn't also mean you're not having a panic attack. In fact, people with panic disorder are twice as likely to develop coronary artery disease. So in order to work this patient up in the ED and rule out some of those other differentials, you might order things like serum electrolytes, glucose, cardiac enzymes, TSH, urine toxicology for amphetamines or cocaine, or a D-dimer to rule out PE. Getting an EKG, putting them on oxygen, continuous pulse ox monitoring, and frequent reassessment of vitals is also not a bad idea, since that is what we would do for any patient coming in with chest pain, dyspnea, and palpitations. Here's the thing about panic disorder and panic attacks. It's probably going to subside while the patient is in the emergency department. You'll continue your workup and get to the point where you can find no other medical cause for these symptoms. So now what do? You need to reassure this patient and provide them some explanation. Don't say things like, oh, it's nothing serious, or it's just stress. This sounds like you don't give a crap and that you lack empathy and understanding. What you do need to do is some patient education. Explain to them that there's a chemical imbalance going on, that they're not about to die, that they're not going crazy. Absolutely advise them to avoid caffeine, energy drinks, and over-the-counter stimulants, and obviously cocaine. Should they have occasion to try a little, just tell them best not to. Probably not. Don't do the cocaine so much. Before you give any benzodiazepines, it is a good idea to involve a psychiatrist. In rare circumstances, you might give some IV lorazepam if their panic disorder is associated with poor impulse control, which makes them a threat to themselves or others. In all cases, you need to refer them for follow-up with a psychiatrist or a mental health professional so that they can get definitive treatment. The gold standard for which is cognitive behavioral therapy, SSRIs, and benzodiazepines. Now that you are sending your patient post-panic attack out the door with appropriate follow-up instructions, you can rest a little easier knowing that appropriate pharmacologic therapy and cognitive behavioral therapy, individually or in combination, have been effective in 85% of cases of panic disorder. The end.